Hi everyone, good to see you. Today let's talk about how to start patients running after an injury. And this is something we've all seen quite a bit. A patient comes in, they have a goal to run again, and while some patients don't get to running, we like to think we can get most people running again. And as we get those patients running, sometimes they're successful and they ramp up, other times they might stay with low mileage. It depends. But let's focus on a couple different scenarios and then talk about how we introduce running to these patients. While some patients don't get better and don't run, which is unfortunate, others do make a successful recovery. But we always think to ourselves, how can we get those patients running that weren't or aren't running? Sometimes patients have the tools to run and they just don't apply them. Maybe with PT, they got to the level right before running, but they never kind of bridged that gap. They never actually were able to implement running. Maybe it was because they were fearful to re-injure themselves, or potentially it was just the fact that they didn't want to get it back into the routine, or maybe they thought that running was just bad for them and that they shouldn't be running, and that they've heard over the years that you can only run for a short period of time and after a while it ruins your joints and that they shouldn't do that. So there's so many reasons and so many different ideas floating out there about why our patients should run or shouldn't run, but as running experts, we need to give our patients tools to be able to run again. We want to make sure they're successful in implementing a return to run. And so that's something that we see a little bit of a knowledge gap in. We see that practitioners will oftentimes get people right before running, and then they'll say, okay, why don't you go try running, without a lot of details or a lot of instruction of how to implement it. So there's a lot of ways you can implement a return to run program, and let's go over some of those today and talk about some of the guidelines that can help patients run successfully. And it first starts with evaluating the patient's readiness to run. We talked about this in some previous episodes. We talked about this in some previous blog articles, and so some of it might be a review, but let's go over it in a little more detail. So when you're evaluating a patient's readiness to run, functional tests are the best way to get the insight into the biomechanics and the good picture of how they move in everyday life. And when I say functional tests, I mean tests that are going to assess how someone looks in their everyday life. This is like your double leg squat or a triple hop test or a single leg squat. Those would all be in the category of a functional test. And so we want to be able to calculate the performance on those functional tests, and we want to take that and correlate it to the patient's risk factor for injury, since that's oftentimes the primary reason patients don't run again or are apprehensive to run. And we can also correlate their readiness to be able to run successfully. Not only can they run without injuring themselves, or hopefully not injuring themselves, can they run for an extended period of time? How much strength do they have? How much can we predict that they're going to run successfully? Where do we start with their ability to run? All of these questions can really be grounded in getting a good amount of functional tests. And obviously, I'm not saying to not take a subjective. I'm not saying to not do other objective tests as well, but functional tests can really help you here. Unfortunately, things like manual muscle tests or range of motion or special tests, they don't really share the whole picture. They will give you a snapshot of the clinical picture. However, they don't really tell you the entire clinical picture, how that patient moves, how they're going to be looking, and how they may or may not be successful when they're running again. So when we come to functional tests, I want to share a couple that we really like. And some of these are obviously practitioner bias. Some of them may not be relevant to your patient. So obviously use your clinician good critical thinking. Think to yourself, what are the best functional tests for my patient, or what might they need? What movements do I need to see to assess their risk factor for re-injury or their successfulness in running? But a couple that we really like, and these are online at solutionseducation.com. You can check out the links. They have normative data with them. They have instructions on how to perform it. Some of them are YouTube videos. So check out the links and you can get a better idea of some of these functional tests. But the lower quarter Y balance test is one we really like. The lateral step down test is another we like. Single leg sit to stand test. Single leg triple hop for distance. Lateral single leg triple hop for distance, medial single leg triple hop for distance, and the functional movement screen. And if you're not familiar with the functional movement screen or the SFMA, which is the practitioner version of it, the FMS, functional movement screen, is something that you can actually have your aide or someone perform. It does not need to be a licensed practitioner to perform it, but it gives you a really clear number through functional movements of that person's risk factor for injury. There's some data behind it. It's a cool test that you can use. Check it out. If you're new to functional testing, it might be a good place to start. So let's say the patient does successful with all these tests and you're evaluating them and you're saying, yes, you are a great candidate to return to running. Well, where do you start with your return to run program? That's a question I get asked a lot. How do you start someone running again? Where do you even start? What do you give them to do? I have outlined a nice chart here online that you can reference if you're listening to this or watching this. Certainly that can be something that may be valuable to go online and see, but I'll walk you through it, no pun intended. I'll run you through it and talk to you about some of the parameters here in some of the return to run program. So let me make a little bit of disclaimer. Each clinician is going to decide where their patient is at in a return to run program. I am obviously not seeing your patient. I am obviously not privileged to all the information you have. So obviously this is not a cut and dry prescription. However, there's some parameters you should keep in mind and some good guidelines to follow, and I'll go through them today. So those guidelines or those parameters that we usually talk about are the patient should maintain their corrective exercise program while they're returning to running. So some patients will get to the running stage, then they'll say, I'm cutting all the corrective exercises, and then they'll start just running. Well, we all know that you need to do corrective exercises. That's why you got better in the first place, primarily, or a good portion of it. So don't cut those out now. Run should be on flat ground, especially in the beginning. We don't want to deal with hills up or down. While going up hills has a little less risk, going down hills can certainly add more pressure, more impact to the system, require more muscle strength, especially going down hills quick can certainly be a risk factor. Runs should also be slow and at a comfortable pace for patients. I don't know how many times a patient has told me, I went out for a run and I did a sub 7-minute mile. Was that okay? And I think to myself, why are you going as fast as you possibly can in your first run out? Tell them to go slow, comfortable pace. It doesn't have to be some artificial number, 9:30 or 10:30 pace, but generally we at least see it's over 8-minute miles. So one good guideline to follow here would be tell your patient to run at a slow, comfortable pace, whatever that is for them. And if they are unsure, get them on the treadmill for maybe a minute and just kind of look at their form, look at the way they're running, and you can probably advise a little bit better. Hey, you're somewhere around 9.5, or 10. And, I would err on the side of conservative. You can always get them faster later. It's hard to have them start running faster and then get injured. The ideal running surfaces are going to include a track or a treadmill, and I say this because there is a certain amount of give to those surfaces, and also because we want to make sure it's stable and uniform. I would not suggest trails. I would not suggest dirt or grass. You might think dirt is soft, might lessen impact, but at the same time, dirt tends to be unstable unless it's a really, really well-maintained fire road. So I would advise a track or treadmill, even a concrete or asphalt. While it's not terribly uneven, they can be a little harder. And so for patients, sometimes if they're comfortable with using a treadmill can be the best way to start. And then they have numbers of how fast they're going. It's very calibrated. It's very static in terms of variable changes. Also, runs should be conducted every other day or once every 3 days, and this is based on the patient's susceptibility to injury or the practitioner's clinical reasoning. Obviously, you don't want to give them to run every day all of a sudden. Maybe you can say, okay, run one day, bike another day, walk another day, if you think they can do some type of activity every day and they really want to. But I would advise at least spreading out the running. I usually start with once every 3 days in the beginning and then kind of wean down once every other day, and then towards the very end stages, okay, try daily or try longer time or try faster pace. Kind of change those variables based on what the patient wants. Some patients want to run every other day. Some patients want to run every 3 days. Some patients say, I want to run twice a week. It just depends on the patient and what the goals are. It starts to get a little bespoke. So let's go through what a progression would look like. And so we talked about the parameters, and I pulled off something from Beth Israel Deaconess Medical Center, and so I can share that with you, and I put that up on here. But it's essential to give patients a break when they're running. And you don't want to just load them up with running all at once. So they have organized it into several phases, and it's not clear when you go through these different phases, but the progression of walking versus running and how many repetitions is helpful. So for example, in the beginning, they say to walk 5 minutes, run 1 minute, do that 5 times for a total of 30 minutes. So really that's 5 minutes of running. And that's a lot of walking between. Now, sometimes you can have patients do 1 minute of running, 1 minute of walking, and do that several times if you're worried about maybe just overall impact. So you can tweak this a little bit. But again, this is a reference point. Then in phase 2, 4 minutes of walking, 2 minutes of running, 5 repetitions for a total of 30 minutes. Phase 3, 3 minutes of walking, 3 minutes of running, 5 times, which is again going to be 30 minutes. Phase 4, 2 minutes of walking, 4 minutes of running, 5 repetitions for 30 minutes. And then phase 5, 1 minute of walking, 5 minutes of running, 5 repetitions for 30 minutes. And then phase 6, continuous run for 30 minutes. And then obviously with proper warm up and cool down with it as well. So that can be an example of a progression, and maybe that takes you 5-ish weeks, maybe 4 or 5 weeks, depending on how fast you want to move your patient through or how successful they are with their return to run program. But what are some other things that can help you? We talked about functional tests. We talked about a return to run program. We talked about some key parameters. But what else can help you really in getting a patient starting to run? And how can you really help to evaluate whether they are ready to run or not? And this may not be a surprise to you, but a running gait analysis can be very helpful. There's a couple things you can do with a running gait analysis to be able to help patients return to run, but at a very baseline level, it gives you the idea and the analysis of how they run. If you can't see how they run, it's hard to predict. Are they going to get re-injured? Are they running in a way that's safe? Is this the running form, or is this the footwear we want to use? So what are the things that running gait analysis can do? We talked about diagnostic. It can give you an idea and help you diagnose the actual origin of the injury. Okay, so you're landing with some overstriding. You're also landing on the lateral aspect of your foot at initial contact. That means that you're doing some overpronation at the ankle. You're doing some valgus collapse at the knee, some hip drop. Okay, this IT band syndrome is starting to make more sense. Here's what we need to correct. So you can use it diagnostically, but with diagnostic info, you can then prescribe different corrective exercises, prescribe different progressions, and also talk about footwear and things like that. So it really is a jumping off point. But it also can help to tailor gait retraining techniques that they can do. So maybe they're at the beginning of their running, they're only running for 5 minutes in that 30-minute period. So it might be easy for them to practice, okay, don't overstride or follow a cadence or keep my feet at least apart, don't let them cross over when I run. Whatever your cues are, they can practice them probably a little easier than when they're just running continuously for 30 minutes straight. That might be a little harder for them. Another thing that the running gait analysis can do is really give you an idea of how their footwear pairs up with the way that they're running. So that's really valuable data, because if your footwear is wrong, or if you're not running in a way that's safe due to your footwear, you want to stop that right away. You want to be able to change it, and you want them to be able to build up slowly with using new footwear. And I do caution you, changing footwear is a big deal. It's very, very hard to implement safe footwear. So I don't say that lightly, just change their footwear. But if you are, you want to make sure you're doing it. And while they're ramping back up is a good time to give them something new to use. And then there can be other things that you could use here. You might want to see cadence. You might want to see speed. You might want to see the way their arms are moving. So there's so many different ways you can use a running gait analysis. Some PTs use it at the beginning of physical therapy. Some use it at the middle, or some use it at the end, or some use it at all different points along the way. The research is really pointing to taking a baseline whenever the patient is appropriate to run, at least for a little while, 2-3 minutes kind of at the minimum. You can then get an idea of how they're running, and then reassess along their journey, because we're just realizing how valuable those running gait analyses are. The problem is running gait analyses can be a little bit intimidating. They can be hard to do. They can be hard to learn. And so if there's any resources we can provide for you, please check them out. We have a continuing education course online, The Essentials of Running Gait Analysis. And if you do have any questions, feel free to either respond to this message, feel free to find the Contact Us page, or reply to one of our emails, and we can answer any questions you have. Or if you just want to talk shop, we love talking about running gait analysis. Let us know what your thoughts are. Until next time, we'll see you next week with different content or new information. Until then, take care and have a great week.